Hello, this is Ileana Pina. I'm at Thomas Jefferson University, and this is my blog. I am thrilled today to have one of my good friends here with me, Dr. Adam DeBoer, who's the director of Transplant at Duke University. There's been conversation about heart donations, and as most all of you, I think, know, we don't have, the hearts are not sitting on the shelf. So when our patients are sick, we really struggle sometimes for months and maybe even years to get a heart for them that is suitable for them, that has the right match, that has the right everything. And hence, a lot of these patients will die. And others will need some kind of circulatory support. So Adam, you have had presentations now about DCD. Define that for us.
Yeah, in the field of heart transplant, DCD is really a game changer. That's donation after circulatory death. And for decades now, we've been doing heart transplants from donors who die or have been declared brain dead. But there's a whole population of potential donors who have very similar neurologic injuries. They're just not technically declared brain dead, who the family would like to donate. And we just didn't have a way before. And so what we and a lot of other centers around the world have been working on is trying to figure out a way to be able to use those hearts to transplant those people in need, as you mentioned.
What's the timing of, let's say, the true death and the recovery of the organ?
Yeah, so this has actually evolved quite a bit. We were lucky at Duke to be the first center in the United States to do a DCD heart transplant in an adult in 2019. It's changed really quickly.
Has it been that long? My goodness.
It was December of 2019, but it's changed so much in just a couple of years. What we've learned is that different hospitals initially had different protocols, and I think we're getting more and more aligned about what that looks like, what donation looks like.
What's your protocol like?
And so in general, we're kind of relying on the donating hospital, but the hospital will withdraw care. Often the family will be present.
Does your organ procurement agency help you, the OPO?
They do, and then we have a team, and then there is a service now that can also help with this through Transplants.
So they give you a call, and they let you know that there's a potential.
That's right. Yep.
All right. And does one of you go to that sister hospital to be present?
Yeah, we either send our surgeons or we use the national service. And one thing that's important to remember is we also kind of pause and tell our recipients, we've identified an organ, but not all of them will be able to be used. It really matters in which the way the donor passes away, which is a little different than a brain death
and the status
donation.
Of that heart.
The status of the heart, that's exactly right. And, because that's something outside of our control and we're never
Do you
quite
cath
sure.
them?
Sometimes we do. A lot of times because they haven't been declared brain dead, that's not allowed by the donating hospital.
So the history becomes important too of that
history,
patient.
The age, everything that's happened. We have done a cath on a heart that was outside the body in one of the ex vivo machines.
Mm-hmm.
Not the greatest pictures. We've also advocated for coronary CTAs that we've done in potential donors.
That might be a way to get around having to cath.
That's right. So we can still learn a lot about the heart. And then there are two mechanisms. So the family would withdraw care. Somebody affiliated with the hospital would declare that the donor has died. There's usually a standoff period. That is a little variable, but it's around 5 minutes.
So they get declared.
They're declared deceased.
That's the clock begins.
Mm-hmm.
Okay.
And then a 5-minute standoff period before donation. And this is actually the part where I think we still have a lot to learn. There are then two ways where that heart could be resuscitated or revived, either outside the body on the organ care system, or could remain in the body through normothermic regional perfusion, where they'll basically go on cardiopulmonary bypass, refuse the heart in the room, and then look at the heart and try to evaluate it before donation. And then the rest of that donation looks just like every other brain dead donation.
How does the family handle this? Because I would think it may be tough.
Yeah,
for some families.
I think it's a great question. I remember when we were first starting this, I was thinking of how would we explain this to potential recipients and what would this look like? And it turns out that something terrible has happened, and families that want to donate organs are relatively enthusiastic and less focused on the details. And so
maybe they've already been gone through their grieving
right.
process, which is
and the same thing on the recipient side. As we talk to patients, they're in need, as you said, they're fearing death, and the exact mechanism of the donation and stuff becomes a little less particular to them.
So how do you set up the program at Duke? How did you do that?
Well, it wasn't me. It was a lot of work over years, but Jacob Schroeder is our head of transplant surgery, really was a big advocate for this for a long time.
Okay, so you have a good surgical partner.
We do. We started thinking about this all the way back in 2016 when we first started using the ex vivo organ care system from Transmedics. As soon as we started using that, he was familiar that they had done this in Europe and said, like, we really need to bring this to the US. And I think you have to credit him and a bunch of other surgical investigators who really pushed for asking for a randomized trial. They said, look, we know this is feasible. We've seen it done for other organs. We've seen this in Europe.
But you need the science.
You need a randomized trial to show that it's safe for patients. How are we going to talk to patients about this without saying,
so did you do that?
We did, yeah. So the DCD heart trial, one of the very few randomized trials that happens in the heart transplant space.
It's really amazing that you were able to do that. How many patients?
So there were 180 patients randomized, 90 in each arm.
Wow.
And
all Duke?
No, not at all at Duke. This was around the United States. We did happen to have the highest enroller, but there were
so you had some other hospitals that agreed.
That's right, yeah. And the patients were randomized right at the time they went on the transplant list to a strategy. Did they have access to DCD hearts or did they not have access to DCD hearts? You think about that for a minute. It's really complicated. Can't randomize at the time of acceptance, so we had to randomize up front.
At the time of really death of that patient, literally.
Right. That's correct. Yeah. And what we found is that there was no difference. It was run as a non-inferiority trial, and there was no difference in terms of outcomes. And if anything, the outcomes favored that we looked at 6-month outcomes in the trial favored the DCD arm, which is really encouraging. It really reinforces this is a strategy we can do to expand the donor pool and offer transplant to more patients.
How many have you done at Duke?
I've lost track. We recently did our 100th, so we've done quite a few. Yeah,
that's a lot.
Yeah.
Well, that's since 2019
that's
to
correct.
now.
Yeah,
okay.
yeah, until now.
What would you tell other programs that would want to do this?
A couple of things. I think one, there is a bit of a learning curve, and we had to really think through, what patients were the first ones for us to think about. But for those patients in the hospital that are critically ill, this was a really important strategy to try to get them transplanted faster before complications happened on mechanical support. And our outcomes have been great. There is definitely, we call it like delayed graft function as opposed to traditional PGD.
Takes a little while?
Yeah, the heart takes a little while. And if you think about it, it's gone through more of a stress than a heart that would.
Do you cross PRAs?
We have basically the same approach.
The same thing.
Yeah, we have no
So you have to know the PRAs of the donor heart as well.
Yeah.
Okay. And when you say it's sluggish, how sluggish?
Well, it's relatively common for people to have to come out on a balloon pump or ECMO support, but we've published on this. It's actually like a shorter amount of time. It's not quite the same as we've seen with traditional PGD where the heart really struggles for 24 or 48 hours. It's really a couple of hours. And as you get used to that, you plan for it, able to support the patient, and they do fine. And, we started with sicker recipients, but we were able to then back and offer to outpatients.
Like a lot of things we do.
Yeah.
What do you do with immunosuppression? Do you give early or?
No differences.
No differences.
We haven't observed earlier rejection. That hasn't been studied in a very rigorous fashion.
So you do your TAC and your CellCept and everything just like you would normally?
Everything's the same. Yeah, we don't treat them any different. We haven't really observed any differences. And when we first started, we were doing MRIs on patients before they went home to look to see, do you see any early dysfunction that you'd be worried about since they did go through that extra ischemic period, and we didn't see any differences.
So how long is your longest survivor now?
So the first one from December 2019 is still doing well.
Amazing.
Yeah, he is.
Yeah, this is so welcome because, we've been through accepting Hep C hearts. We went through that. Do we accept COVID? Previous COVID patients.
Right, yeah.
So there's so many of these. It almost sounds like a little bit of a redemption to be able to donate.
Yeah, as you know, this goes on
in the horrible
impacts
death.
A lot of lives.
Yeah,
that's absolutely right.
Well, I hope you get this published soon, and I'll be excited to see if it comes to Jefferson.
That'd be great, and we'd love to work with you guys. As you
talk to our guys. For sure. Thanks
good.
For joining me, and thank you for joining me. This is a very exciting and different approach to getting some of our patients the organs that they so need and that we just don't have enough. In your own communities, encourage donation, encourage to become an organ donor, because that is also equally important to us to have it in the community. Thank you for joining me today. This is Ileana Pina signing off.